Welcome to this month's, our first of the academic year, Health Policy Grand Rounds here at UCSF. This is a hybrid event. Some of us are here in our conference room and others who are on site are welcome to join us here. And our speaker, Dylan Roby, is remote. I'd like to begin by acknowledging the Ramaytush Ohlone people who are the traditional custodians of the land that we are on. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We're proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. I am very happy to have today Dylan Roby, who is our inaugural Grand Round speaker for this academic year. Dylan is a professor of health policy and the chair of the Department of Health, Society, and Behavior at the UC Irvine Joe C. Wen School of Population and Public Health. And this is a fairly new School of Population and Public Health in the UC system, so we are very excited to have a growing community of colleagues at UC Irvine. Many of us at IHPS have known Dylan for many years, and it's good to have him back in California. His research focuses on access to healthcare, health insurance coverage, and the delivery of care through safety net providers and programs. He was associate professor and associate chair at the University of Maryland School of Public Health, their Department of Health Policy and Management from 2015 to 2021. But before that, he had been at UCLA for quite a long time, and we are very glad that we stole him back from Maryland to continue to collaborate with people in California and continue his research, a lot of which has been California focused for many years. So I'm going to stop there. I could go on and on about how much I admire Dylan's work, but I won't. And I will let him take it away with his presentation. So Kat, if you could please mute the conference room, that would be fantastic.
Great. Thank you, Joanne. I appreciate the invitation to speak today, and I'm happy to see some of you in the room. I think I saw Janet Kaufman walk in, so great to have some longtime colleagues. Folks are waving, so great to see you all. So I'm here to talk a bit about the recent 2025 Budget Reconciliation Act, HR 1. Some call it the Big Beautiful Bill, but there's been kind of resistance to using that name. Charles Schumer had a motion on the floor to just rename it HR 1 and remove OBBB from our lexicon. So I'm trying to respect that. And so I'm going to talk a bit about health coverage impacts of that bill, as well as what we're seeing in terms of California's budget related to the bill partially, but also related to our own budget shortfalls. So I'm happy to be here for Grand Rounds to discuss it. So I did want to talk a little bit about background. I'm not sure, what students are in the room, medical students, folks who are pursuing health services research. And I just wanted to explain kind of, most routes to health services research aren't very linear. And so my educational background, I grew up in California in Riverside. I went to UCLA for undergrad, where I was pre-med and a geography environmental studies major. And I fortuitously took a class from Mike Dukakis, who had run for president against the first Bush in 1988 and famously lost. And he taught a class on the American presidency. And my project in that class was to focus on what went wrong in the Clinton healthcare reform attempt. And that really got my interest and led me to kind of pursue a career in public policy. So I ended up pursuing a PhD in public policy at George Washington. But in between there, when I was in undergraduate, I had the fortunate experience to work for Rick Brown, Jerry Kaminsky, Nadi Parat at the UCLA Center for Health Policy Research, which really kind of solidified my career path for me. I then moved to DC. I worked at a variety of think tanks, National Governors Association, Public Policy Institute. I also worked closely with the National Association of Community Health Centers on federally qualified health center issues. And what I found was I was drawn to generating academic research that would fuel policy discussions, but I didn't necessarily want to be on the policy side in those think tanks and trade associations, because I started to put the pieces together and understand how important researchers are to translating evidence so that people can make good policy decisions, and that a lot of that the role of a trade association is to kind of disseminate and use evidence to guide their decisions, but they also have their own political stake. And so that drove me to kind of sit in this world of being in applied policy centers and try to do both policy analysis and research that would inform policy decisions in a more timely way. So I focused my career mostly on healthcare access and coverage, the real emphasis on public hospitals and community health centers, and vulnerable populations in Medicaid. But a lot of that led to a project that's over a decade old now, the California Simulation of Insurance Markets model, where we do a lot of work to model the impact of different reforms. And the reforms I'm going to talk about today are things we're modeling currently, and we're not yet done. So I'm kind of synthesizing the evidence out there around what's going on with the HR1 passage and California's budget. And hopefully in the next few months, we'll be releasing some additional analysis that really targets what the impact will be on California to specific numbers and specific populations. Because we have lots of work with Covered California and other entities to try to guide them in terms of what decisions they might make in the future. It's really that career path to focus on kind of applied research, I think has been a very fulfilling and interesting one. And, I'm very lucky to have joined a school that is newly developed that did not have health policy, um, dating to 2020, 2019 when the dean was hired. And I was privileged to be able to join the faculty in the Department of Health, Society, and Behavior and start building health policy capacity at UCI that usually sat in the School of Medicine or in the School of Business and not in the new School of Public Health. And we have new MPH programs in health systems and policy and a new PhD program in health society and behavior that will allow folks to get health services and health policy training at UCI in Orange County, which hasn't been at the forefront in a lot of the health policy discussions. So I'm not sure if I'm here for grand rounds or M&M because this is kind of feels like a post-mortem to me in terms of the politics behind the passage of HR1, which was signed into law July 4th, 2025 by President Trump. So I will probably couch some of my discussion a bit in like why things happened politically in the passage of the bill, and why we ended up with probably a smaller impact on Medi-Cal and Medicaid federally, than if key Republicans had not been resistant to certain changes that were um, prioritized by leadership in um, the Republican Party, but not necessarily by key senators and constituents at the ground level. And we're seeing some resistance to the changes made in Medicaid already. I think Dan Crenshaw had a town hall recently where there was kind of shouting him down around the Medicaid cuts. And so I think this will probably go down as a difficult vote. The changes to Medicaid that are made by the law are going to be pretty substantial, but many of them are pushed out until 2028 after the midterm elections. But we'll probably see some significant repercussions long term politically for those who might have signed on to the bill or just the Republican Party in general around Medicaid. The other thing that I'll probably talk about a bit is the expiration of the more generous advanced premium tax credits, which were created by the Inflation Reduction Act. They were not touched by HR1, but they were also not extended by HR1. So those are set to expire December 31st, and we'll kind of go into the impacts of those as well, and talk about the timeline for when to expect different changes, and also talk about how California is responding and also responding to their own issues around shortfalls in the state budget related to lower revenues than expected. So there are a few core components of HR1. Like the main goal of HR1 was not to change Medicaid, but was to continue the 2017 Tax Cuts and Jobs Act tax changes, right? With changes to SALT taxes, changes to corporate taxes, lowering the marginal rate, things like that for certain populations, which largely accrued to higher income individuals. And so the attempt was to extend those. So in 2017, when they were passed, they were also part of a reconciliation bill, which meant they were temporary for a 10-year period of time and were set to expire at the end of 2026. So this was an attempt to extend those permanently, but that costs money. And so in order to find the money to make those tax cuts permanent, they had to cut public programs and other allocations for spending, um, that normally wouldn't have to be touched except for the expiration of this bill. Um, but because of the lack of a filibuster 60 vote majority in the Senate, Republicans had to use that same budget reconciliation process to pass the spending package, which means they can pass the package HR 1 with a simple 50 vote majority with JD Vance breaking a tie. Um, and a simple majority in the House as is typical, but they weren't going to be held back by the 60 vote requirement in the Senate. That being said, if you're doing a budget reconciliation bill and you're trying to move things to the Senate, the legislature doesn't know really what's budget related or not. There's some intuition and feedback there that occurs through the Senate parliamentarian, Elizabeth McDonough. And so there are provisions in the bill that were introduced and that were stricken out of the bill because of the parliamentarian saying this element you're introducing now and you're trying to pass in this package would require a 60 vote majority to pass because it is not directly related to the budget. And this is a budget reconciliation bill. So if you don't do something about it and make it budget related to pass my tests, then you have to pass it with a 60 vote majority. So there are kind of broader issues that were in original versions of the bill or earlier versions of the bill that were taken out or adapted to meet the parliamentarians' needs. But it did allow the Senate to continue to pass something, but it was probably a milder version of what the intention was to pass. And so you'll notice, for example, in early versions of the bill, the target for Medicaid spending cuts to offset the extended extension of tax cuts was around $1 billion. That was supposed to come out of Energy and Commerce, which was the Committee of Jurisdiction in the House reconciliation bill. And it ended up coming down to about $800 billion in spending that was cut from Medicaid and other related programs. And so the cuts were less significant in Medicaid than originally planned, but they were still fairly significant. So even though Democrats were able to avoid Medicaid per capita caps and block grants and changing of the federal medical assistance percentage from 90% in the ACA expansion population down to the regular state's FMAP rate, all of those things were kind of pushed back on either by the parliamentarian or because certain senators like Josh Hawley, Susan Collins, Lisa Murkowski said they wouldn't vote or support the bill moving forward if those provisions were left in. So you ended up with kind of some more incremental tinkering that occurred. That's kind of harder to understand and synthesize, unfortunately. And that is very in the weeds of Medicaid policy, but it still has substantial repercussions to be able to save $800 billion in spending. So taken together, after cutting that $800 billion in spending from Medicaid, cutting some funding from, student loan programs, the SNAP program, it ended up that I believe the overall bill will still add quite a bit of money to the deficit, probably around $3 trillion over 10 years. And about 10 million people are likely to lose coverage by 2034, so the 10-year cycle, with 7.8 million of those people coming from the federal Medicaid program because of changes that will have to occur at the state level to absorb those cuts or new requirements that were put in place to reduce the size of Medicaid or at least make it harder for people to stay on Medicaid. So here's a timeline of some key federal state policy changes. This is available through, Lisa Chan Sowen from Transform Health presented this during a California Endowment webinar, and I thought it was a great way to kind of explain what's going on at the federal level and the state level, and with the issue around the California budget passage. So anything in green is a federal change, anything in purple is a California budget change. And we'll revisit this later, but it gives you a sense of the timeline is like basically summer 2025 through 2028 are when we'll see a lot of the things either introduced or implemented, and then quite a few things. The biggest impact will be felt in 2032 because there's some elements that are phased in over a 4-year period starting in 2028. But many of the visible state Medicaid changes at the federal level are pushed out until an implementation after the midterm elections in 2026. So you'll see work notices for work requirements will go out in September of 2026, which may impact election results for the midterms, but the actual work requirement and people doing more eligibility determination, having to turn in paperwork to stay on Medicaid will start January 2027, just after that window. So um, I don't know what impact the bill might have overall on the midterms, given some of the changes introduced are going to be delayed a bit, even though they were able to take credit for the spending in those years, or the spending changes in those years. So I'll go through kind of the big buckets of provisions, and there are a few things that kind of don't belong anywhere in my categories, so I'll try to touch on those as well. So one of the big changes will be work requirements in Medicaid. So it requires adult non-disabled, or what a lot of the legislature were calling able-bodied Medicaid enrollees, aged 19 to 59, I believe, to report on community engagement activities. So it's not technically in law called a work requirement, it's called community engagement activity. And so people will have to report if they fall into this category, which is basically the Affordable Care Act expansion category of parents who are a little bit higher income than previous state law, and then all the childless adults who came in due to the ACA. It really only it applies in expansion states because that's the only place where these folks are. Like 1931B parents are excluded from the requirement because they came in as an old Medicaid, traditional Medicaid parent. So it's basically any ACA expansion childless adult, as well as a parent earning between 50% and 138% of the federal poverty level with kids over the age of 13 would be eligible for reporting. And they'd have to report 80 hours per month of work, student status, volunteer activity, being in an organized work training program, or other sorts of kind of work substitutes to show a level of community engagement. Um, the regs have not been written yet. They are going to be written for June 1st, 2026, where there'll be a public comment period, and then states will have to require reporting starting January 1st, 2027. Like I mentioned, notifications of the work requirement reporting will go out September 30th, 2026, and then in every like 3-month window, um, people will be asked to report on their work status in a given once in a given window. So January to March of 2027, they'll get a work reporting requirement, either paperwork or there'll be an automated test of the requirement. So, for example, California, if we wanted to be very proactive about things and keeping people on Medicaid, might set up an agreement with Employment Development Department to check for, um, unemployment insurance payments coming from payroll, so that automatically you would know somebody's working and they satisfy the work requirement, and you don't have to go after them with mail-based or email-based paperwork. Um, and so this will go into effect. Really in 2027, and about 5 million people are estimated to lose coverage throughout the country by 2034 because of this provision. And it saves about 300 billion of that 800 billion dollars that was cut from Medicaid overall in the bill. So 5 million people out of the, you know, 20 million people who ended up enrolled through the ACA expansion is a substantial change, right? So the ACA expansion population, which usually is around between 18 and 20 million nationwide in those expansion states, would shrink by about 25% over time due to, barriers to reporting, actual lack of work or lack of meeting certain requirements, but also just, things getting lost in the mail or forgetting to re-enroll and things like that. So we'll see the same issues with redetermination that we might have seen in the past as well. So it just adds another barrier of reporting. And to give you a sense, like 60% of the Medicaid uh, folks already work, um, but they um, they may not be working 80 hours a month. Um, and then there are some folks that have been kind of demonized as not willing to work, even though they're technically able-bodied. And there have been several papers about like video game consumption among low-income people that have really tried to demonize this population. But it's actually a very small, like less than 10% of Medicaid enrollees in the ACA, in the overall population, non-elderly 19 to 64 are not working. So that's the work requirement component. So that's probably the largest change in terms of like um, the goals of Medicaid and also the dollar amount saved over that 10-year window. In addition, there's some provisions around Medicaid eligibility that will also change things quite a bit. So one big one that probably will be undetectable to most voters is the end of federal matching for refugees, asylees, humanitarian parolees, and domestic violence victims and other victims of violent crime who are currently allowed into Medicaid, federal Medicaid, with matching funds coming from the federal government to the state, even if they haven't been living in the US for 5 years or more with a green card. So we're used to from a federal perspective saying, okay, low income citizens and low income people who are lawful permanent residents who have been living in the US more than 5 years with a green card are in federal Medicaid. But this specific group, refugees, asylees, humanitarian parolees, NDV victims, have been assumed to be qualified immigrants, even though they haven't met the 5 year eligibility bar. Probably for the past decade or so. And that protection now goes away. So anyone who meets that current category, their federal matching would go away. The state will probably continue, is going to continue, at least in the short term, to cover them. But it will have to be with state dollars only, not with federal matching funds. In addition, so anyone who is like presumptively eligible for Medicaid or emergency Medicaid triggers matching funds that the state can rely on to pay for services. This population will now see if they're a childless adult, let's say, that was triggering a 90% federal match because they're part of the ACA expansion population in California, would now only trigger a 50% federal match instead of the 90%. So California will not only be paying state money to cover them completely, but they'll also be paying more state money to deal with their emergency Medicaid if they're not on Medicaid permanently or for the long term. They will also be changing the frequency of Medicaid expansion redetermination. So right now it's 12 months. There will be checking required by federal law every 6 months, starting in January 2027. And then you have retroactive eligibility, which happens when somebody applies for Medicaid. Typically, let's say they apply at point of service at a federally qualified health center, they would get Medicaid that covers the time they applied and 3 months prior. And the federal law will change that so that retroactive eligibility is only for 1 month prior to application for those in the ACA expansion population and 2 months prior to application for the non-ACA traditional population. So retro enrollments will be more limited in terms of if providers are able to get reimbursed for the services they deliver during like a time of uninsurance before the application than in the past. And that'll go into effect January 2027 as well. There was also a newly introduced home equity limit of $1 million for seniors needing long-term care. So that it's kind of like an asset test in essence, so that if somebody spent down their income to get into skilled nursing through Medicaid, if they had a home that was worth more than $1 million, then they wouldn't be allowed into the Medicaid program. There's also a new contact information requirement that will be enforced more actively starting on October 1st. And all of these eligibility provisions taken together are designed to save about $200 billion of that $800 billion bucket. So the next provision is a little more wonky. It relates to provider taxes. So as I mentioned, like Republicans initially pushed for let's just slash the FMAP rate from 90% down to whatever the state is getting now. So that'll save a bunch of money in kind of a blunt instrument type way. But when certain Republican senators, Hawley, Collins, Murkowski, Tom Tillis from North Carolina, who are all in expansion states, said, wait a second, we can't do that. Then they started kind of making changes to programs that they probably disliked and knew that there was some room for compromise. So, for example, provider taxes are something that's kind of been a concern for years. There are old GAO reports about how states use provider taxes, and many of the states who have Republican senators voting on the bill also are living in state or they represent states with provider taxes. So they don't want to completely remove provider taxes because they know their state needs to be able to pay for their program, but they wanted to limit it more. So One way of doing that is to cap the amount of um, the fees that can come from that can be taxed, um, or the amount of taxes that you can generate that will then be passed back through in fees. So if you think about a provider tax, like for example, we have an MCO tax, a managed care organization tax here in the state of California for Medi-Cal managed care. And so I believe the rate for Medi-Cal HMOs have to pay $274 per member per month to the state as a tax. The commercial non-Medicaid plans have to pay $1.75 per member per month for their enrollment. And the state takes all that money together and then uses it to pay the Medicaid MCOs higher rates in Medicaid when they spend all that money in terms of premiums paid out to the plans, which let's say are now $1,000 instead of $900. They then are getting matching funds on that $1,000 they spent. So they're getting $5,500 dollars per month for the regular Medicaid population. They're getting $900 back a month on the ACA expansion population. And so we're basically using those taxes to fund the state share of Medicaid. So that's why even though we have a 50% and 90% matching rate, the state of California really spends about 30% of state money on our Medicaid program. About 70% comes from the federal government. So Congress is trying to reduce the amount of federal share that's flowing into Medicaid and increase the state contribution to Medicaid by reducing provider taxes. So there's a 6% safe harbor limit right now, and California is at about 5.03% in terms of our provider tax for um, MCOs and other providers that we have deemed appropriate. And that'll be reduced down from 2028 to 2032 until we hit a 3.5% rate. So you can envision in 2028, if we're still at 5%, it'll get reduced down to a cap of 4.5% for 2029. Then it would go down to 5 by 2030. Then it would go to, I'm sorry, 4.5 down to 4 by 2030. Then it would go to 3.5% by 2031. And then we would stick at the 3.5% level. So in essence, it kind of reduces our provider tax allotment by 42% over time, which generates, almost double that in provider tax, a little bit over double that in actual revenue from the federal government that we then pass through to Medicaid providers. And remember, Prop 35 kind of codifies that we should be using provider tax dollars to pay better rates to providers, but it holds back about $2 billion and says there's a cap on the amount of money the governor or the legislature could take from the provider tax revenue we're collecting and use it for other purposes. And so this year, for example, in the state budget, about $2 billion from the provider tax fund was actually used to plug another hole in the state budget rather than directly on provider fee increases as they might have designed in a different budget year. The federal law will also not only reduce the amount from 6% to 3.5%, it also prohibits provider taxes that are higher for Medicaid versus non-Medicaid businesses. So right now in our MCO tax, we would be non-compliant because we're doing $274 PMPM for MCOs in Medicaid and $1.75 PMPM for employer-based and individual market insurance. And so we'd need to spread that out to equalize the tax burden across providers and MCOs to be compliant with the new federal law by 2028. So that will occur as well. And so right now, like we generate about 14 billion a year in additional revenue, probably about 70% coming from the feds. So we would stand to lose a billion and a half dollars from this change pretty quickly in 2028, and then it would kind of scale down. But this provision is estimated to save the federal government between 100 and 200 billion dollars by 2034. And then something that's kind of related to provider taxes but is different is something that's come up since 2016, which are something called state-directed payments. There's another provision in the bill. So right now, we use state-directed payments for certain services, and we can either add to the fee schedule, we can use it for value-based purchasing, so kind of like the DSRIP incentive payments, that sort of thing. That wasn't done through a state-directed payment, that was done through a waiver. But there are similar programs in multiple states where if a hospital is performing well in a certain way, they will get additional payments, and because they are passed through a managed care firm, um, those bonuses are then subject to federal matching, but the state is allowed to directly tell the managed care firm how to pay. So, right now, the benchmark issued based on regulation that's been issued during the Biden administration is the average commercial rate. Um, the law, the HR1, will change that so the benchmark would become 100% of Medicare and expansion states and 110% of Medicare and non-expansion states. So the benchmark for prices will be lowered. And so the state would be able to say, okay, um, LA Care, we or any HMO, we view primary care as very important. So we are going to require you as the state to pay primary care providers in your network 100% of Medicare for primary care services or evaluation and management services within your Medicaid population. And in a non-expansion state, they would get to pay 110%. So they're basically directing the MCOs to pay a certain fixed rate um, to a provider, and rather than supplementing it outside because it's illegal to supplement fee for service, supplement um, managed care payment with additional supplemental payments. We're used to seeing supplemental payments on the fee for service side because that's technically legal, where you're kind of adding things like additional payment for a delivery or a complication to our DRG versus requiring an MCO to do it. So if we think about the managed care organizations negotiating rates with different providers, they are required through these state directed payments to pay a certain rate at minimum. And it used to be the average up to the average commercial rate, and now there wouldn't be matching available. If you went up to that rate, you would have to stick to 100% of Medicare for the state of California. So if a plan was previously approved prior to May 1st, 2025, it's good. But then in 2028, they will start reducing it. But there are no new state-directed payment agreements allowed for now. There are certain exemptions. So like Hawley, Collins, Murkowski were able to get payments to rural hospitals exempted. So a Medicaid, Medi-Cal could decide we're going to reimburse rural hospitals at the average commercial rate, and we're going to urban hospitals will get 100% of Medicare, and that will be the kind of the pass-through role. Um, and if there's no published Medicare rate for the service, it defaults to the Medicaid fee schedule, which of course is a bit lower. This estimated savings here is about $70 billion over 10 years, so it's smaller, but it's still a substantial change, and it'll cause a lot of around negotiation at the state level around how to do this. This was a big sticking point for the senators I mentioned before who had a lot of power in the process. And so they were convinced to vote yes on the bill. Well, Murkowski wasn't, but I think Colley and Collins were, because there was a creation of a new rural hospital transformation program that has already started. So I believe the funding opportunity is going to be coming out in September sometime. There's already a website for it called, and the email is like Maha Rural at CMS dot, DHHS.gov to do applications to get money from this rural hospital transformation program that's designed to kind of shield state-directed payment and provider tax um, participants from some of the big cuts, especially in rural states, which are, predominantly Republican. So there's half of the money, so $10 billion per year for 5 years, total of 50 billion. Half of the money is just supposed to be allocated based on state kind of share, and then the rest will be kind of innovative programs and more of an RFP style process. So if you are partnered with like a rural hospital, you might be able to go for that money to do innovation, but also just, to an extent is designed as a bailout fund with lots of flexibility that CMS can deliver. So you can see here that there's a variety of different directed payment programs. This is a MacPac report that kind of explains that there are 302 different approved directed payment programs in Medicaid across the country. They often are dealing with nursing facilities or physicians or hospitals, and the way things are done, whether it's a rate increase, value-based purchasing, or setting a minimum or maximum fee schedule that the managed care plans have to live by, and then the money kind of gets passed through, um, is available to look at if you're interested. So those are the majority of the big Medi-Cal changes, or the Medicaid changes broadly. There are a few other things. So, for example, the law requires, and this may be on a subsequent slide, but the law requires $35 maximum copayments for Medicaid beneficiaries in the expansion population for services, excluding FQHC services and behavioral health services. California might say, okay, well, we're not going to charge $35, but because we need to comply with this law to create a copay for Medicaid beneficiaries for certain services, we're going to charge everybody $1 or $5, but it still might add an extra barrier and administrative burden to use of services even after the Medicaid eligibility changes. So there are some things like that that'll go into effect um, in 2027, I believe, as well. Um, there are also provisions related to marketplace insurance. So, Covered California and healthcare.gov. One of the big ones that people haven't really been aware of is there are currently caps on repayment if you misreport your income. So if I go into the exchange in open enrollment in October, and let's say I'm earning 200% of the federal poverty level, and I get pretty significant subsidies to buy my coverage in the exchange, and let's say it amounts to $200 a month, so $2,400 throughout the year. If at the end of the year I'm filing my taxes and it turns out that I earned 250% of federal poverty level, and I would owe back $100 a month, $1,200 for that service, the ACA includes this table that says, if somebody's earning less than 200% of poverty, then they're held harmless to where they only have to pay back $600 of their overage. But the HR1 removes all of those caps on repayment penalties. So now the rule will be starting in 2026, if you report your income and you come in a certain subsidy level and that changes over time and your income changes at the end of the year when you're filing your taxes, you have to pay back all of your premiums if you get it wrong to a high extent. So people who are higher income used to have to pay the full premium back, but now even low income people, if they get their income slightly wrong, that moves them into a different tax credit category, will have to repay it completely as well. It also eliminates tax credits if you enroll in a special enrollment period due to income rather than a qualifying life event like a birth or death, etc. There is one positive thing. It allows bronze and catastrophic plans to be considered HSA eligible as federally recognized high deductible plans effective in 2026. It basically gets rid of auto enrollment because there's a new requirement for pre-enrollment verification before putting someone in a plan. So right now, according to federal law, you can, if you have somebody on like a $0 plan in 2027 and they don't do anything, you can just continue them into the plan and auto enroll them without asking them. Now there'll have to be this verification and an active opt-in. So you'll expect people to potentially not continue coverage after 2028 because of that barrier. Um, there's also a group, again, with related to lawful permanent residents. So if you are a lawful permanent resident who's under the 5-year eligibility bar, in most states, you're not eligible for Medicaid. In California, you are using state dollars. But in most states, you then went into the exchange. And if you were earning 100% of FPL or less, because you didn't have access to Medicaid, you were allowed to use subsidies to buy coverage in that exchange, and they were very generous. So you could get a plan for like $20 a month that was 94% actuarial value and very comprehensive. They're removing that provision. So anyone under 100% of FPL who's a lawful permanent resident under 5 years will fall into the same Medicaid coverage gap that citizens have been falling into in states that didn't expand Medicaid in the past, or even in states that did expand, but they haven't met the 5-year eligibility bar. So the CBO estimates that the Medicaid provisions will probably cause 7.5 to 7.8 million people to lose coverage. The marketplace provisions will cause about 2 to 3 million people to lose coverage. Then it comes to things that weren't touched on in the bill. So expiration of enhanced premium tax credits, advanced premium tax credits in 2026. So the Inflation Reduction Act includes additional tax credit help for people lower on the income spectrum, but also higher on the income spectrum. So it used to be that the ACA cut off at 400% of FPL. If you were under 400% of FPL, you got tax credits to help you buy insurance. If you were over, you fell off this cliff and you got no help at all. But the ARP and IRA fixed that temporarily where people even at 600, 700% of FPL were capped at 8.5% of their income could go to buying a second lowest silver plan available in the market. But because there hasn't been congressional action on this and open enrollment is coming up, rates are currently being released by states under these new assumptions. Those extra tax credits will likely expire December 31st, 2025, and we will see this big increase in out-of-pocket premium payments, especially among higher income people, but also among some lower income people, for their plans effective January 1, 2026. And so the assumption now is that people who fall into this group will opt out to a large extent, and we will see a worsening in our risk pool, and probably increases in premiums. And so, like the 10.3% increase that Covered California announced a couple weeks ago, that includes the idea that people will opt out, and we will end up with, instead of 1.8 million people or 2 million people in covered California, we may end up with 1.6 million people in covered California, and a lot of the 400,000 that would have exited are going to be folks who can go without insurance because they're slightly healthier, and that's why we might have some adverse selection concerns. So the premiums are likely to go up quite substantially. So this table is from Covered California, is in their August board meeting, where basically these are folks, 62,600 is 400% of FPL for an individual. So if I'm in the subsidy group already, like the ACA subsidy group, I'm getting extra help that amounts to about $50 to $100 a month, depending on my income. And so that would go away. In addition, if I'm over the 62,600 mark and I'm making over 400% of FPL, you can see here this goes from, I think, 400% of FPL all the way up to 700% of FPL, at least at 93,900. So that would represent almost a doubling in premiums for some people. So if I'm kind of 400 to 500% of FPL, my premiums will go up by $500 because I'm not getting any tax credit help to buy coverage. And so we're expecting a lot of those folks will either opt out of the exchange completely or go into a cheaper plan or go onto the open market through a broker, buy coverage, or go uninsured. And it's estimated that about 150,000 Californians who are currently in the individual market will become uninsured due to that provision or that lack of action. And this gives you a kind of better sense among 55 to 64-year-olds. So 55 to 64-year-olds, based on the rating of premiums, if they are going in with no subsidies to buy coverage in Covered California, they're often asked to pay about 30% of their income or like 25% of their income out of pocket to buy those premiums, even if they're higher income. And right now, under the IRA subsidies, that's capped at about 11% of their income. It's technically capped at 8.5%, but the 8.5% only buys them the second lowest silver plan in the region. And so if somebody upgrades, they have to pay out of pocket for some. So that 11% is kind of actual spending according to Covered California's data. And it'll primarily target AAPI, Black and Latino beneficiaries, where they will see a larger increase in loss of premium help. But overall, the premiums will go up by about 97% on average. So they're basically doubling January 1, 2026 for especially the higher income group. So we anticipate, right now we have about 2 million people in the individual market in California. 1.6 million receive tax credits to purchase insurance, and they're going to expire for about 200,000 of them. California has been adding state money to zero out deductibles. So if anyone in California right now in 2025, regardless of income, if they sign up for a Silver 73 plan using subsidies, they have no deductible at all. So that's been zeroed out. So if you look at their table, basically the NA means there's no medical deductible right here in the middle. And all of these things are first dollar coverage, all the blue cells. In 2026, there won't be money for that anymore because of the federal changes. And so Covered California has decided in their last board meeting to put all of the state funds available toward additional premium subsidies to those earning up to 165% of FPL. But the free deductible will go away for everybody So they'll be hit with both a change in their benefit design and cost sharing, and also a change in premiums that's pretty sizable, especially for those who are higher income. In terms of California's budget deal, so there's a larger shortfall. Some of the elements of plugging that shortfall were, spending the Medicaid provider tax dollars from Prop 35 in a different way, but there's also a pretty significant provision that will go in effect this coming January to freeze enrollment for those in the undocumented expansion who are age 19 and over. And in addition, on top of the undocumented folks, there will be those with unsatisfactory immigration status now, according to federal law, which it's that group I talked about before, refugees, asylees, humanitarian parole, domestic violence, etc. Those will all, because they are not under the 5-year eligibility bar, or they're not compliant with the 5-year eligibility bar, and now there's no federal money to support them except for the 50% match on emergency Medi-Cal. They will now be charged $30 monthly premiums to continue in the program. So basically, UIS, unsatisfactory immigration status, represents about 2.1 million people in Medi-Cal today. 1.7 of them are undocumented. 400,000 of them fall into this like previously federally protected matchable group, refugees, asylees, etc. That protection has gone away. There's a new definition of what a qualified immigrant will be. So they are now categorized as unsatisfactory immigration status. And if they're ages 19 to 59 in that category, that 400,000 person group, or the undocumented category of 1.7 million, they are all being charged, if they're 19 to 59, a $30 monthly premium. If they forget to pay the premium, they will lose coverage. There will be a um, 3-month grace period so they can come back in, but after that, they would lose coverage completely if they didn't pay that premium again. And because there would be a freeze on enrollment for the undocumented, they wouldn't get to come back. So this could have pretty significant repercussions where we estimate like probably, 500,000 or so people will lose coverage in the next couple years just because of these changes and the added premium and also the freeze on enrollment. The budget also restores the asset test for Medicaid, but it's at a higher level. So it's $130,000 for individuals. Many of us remember the time when, which wasn't that long ago, where it was a $2,000 per individual, $3,000 per family asset limit, but now it's 130,000 plus 65 for each additional member. So there will likely be an increase in California's uninsured. It's estimated by Kaiser Family Foundation that about 1.6 million people will lose coverage by 2034. Of those, 1.3 million will be from Medicaid, and about 230 will be due to the ACA expiring tax credits. Um, and as I mentioned, there's no real data on the UIS and undocumented group that's going to be frozen and then charge premiums. But we expect probably, more than 500,000 to disenroll over time, and that freeze will probably be kind of difficult to navigate for a lot of people. And the freeze goes into effect January 1, 2026. The premiums go into effect July 1, 2027. Overall, like taken together, all of the changes on the Medi-Cal side in the state budget um, this fiscal year, it doesn't create much savings because of the kind of staggered implementation. But year over year, it's probably about $1 billion saved from the state budget each year by making those changes that were designed to kind of fill that shortfall. So we could have about 2 million additional people losing insurance in California by 2034. So kind of concluding remarks, although less damaging than expected back in January when, the inauguration was happening and big promises were made about this big, beautiful bill, HR 1 kind of was able to accomplish quite a bit of Medicaid cuts through the jurisdiction of budget reconciliation, dealing with the parliamentarians, decisions that really will probably result in people losing insurance coverage and also providers being paid less and states getting less federal money from their Medicaid programs. And a lot of the focus has been on cutting programs that really benefit expansion states and kind of holding the non-expansion states harmless. So um, a lot of the savings will be generated by changes going on in California, New York, and larger Democratic states than they are from conservative states that haven't expanded. um, there's also provision I didn't mention that's in the timeline around restricting abortion payments or restricting Medicaid patient payments to anyone who provides abortion services. And I mentioned the cost sharing issue. There's also uncertainty for the state in 26, 27. We may have state revenue shortfalls caused by broader issues around tourism, tariffs, employment, et cetera. And on top of that, we'll be facing pending state higher state share for Medicare and for Medicaid. And so there's concern that the state will have to cut even more to the optional expansion groups to benefits when the full implementation of provider taxes and state-directed payment limits really go into effect from 2028 to 2032. On top of this, because this reconciliation bill added to the deficit, there's a trigger, I believe it occurs next year, January 1, 2027, um, where Medicare sequestration requirements will go into effect, and there will be an automatic cut to Medicare. So next year in Congress, there should be an attempt to plug a hole in the budget that would result in automatic Medicare cuts through because of sequestration requirements that were agreed to quite a while ago in a different budget deal during the Obama administration. So happy to take any questions you might have. And thanks for, sitting through all of these changes. I know they are significant, but also difficult to follow and navigate. So I'm hoping it's helpful for everybody.
Thank you, Dylan. That was great information and a really wonderful summary of a lot of sobering data, to say the least. So there are a few questions that have come in for the webinar. For people who want to ask questions that are on remotely, you can type your questions into the Q&A box. And for those of you in the room, you can kind of quietly raise your hand and then we'll let you have the microphone in here. But I'll start with one of the online questions that came in pretty early on. And that is, what is your take on whether Congress might pursue another reconciliation package later this year with more significant Medicaid cuts versus, than the things that were struck from the final version of the HR 1? Do you think they might be pursuing another package to enact those cuts over the next year or so?
Right. So I don't think there's a lot of motivation around pursuing the same cuts they were trying to get. So like the FMAP rate, the block grants, per capita caps. Basically, you have Hawley, Collins, Murkowski, Tillis all saying like we will not support a reconciliation bill or any bill that has those provisions in it. So I think they've gotten all they can from Medicaid, at least in the short term, like over the next 3 to 4 years. There could be another reconciliation bill. So I'd have to look at the deadline, but I'm pretty sure Republicans do have an ability to take another bite at the apple as long as they pass another budget resolution by November. However, they're currently fighting over appropriations. So, Tom Cole, who's the chair of House Appropriations, there are 12 Senate appropriations bills that have already been approved. The House was supposed to take them up after coming back from summer recess this week, and Cole has said, like, we're not going to get all these done, so they're looking to push the budget deadline for the appropriations bills for FY 26-27 out to November 20th at least. And so I don't think they will have enough time to get through appropriation and do that business. That being said, if there were lots of problems within their own caucus, they could try to push a reconciliation bill to deal with those 12 appropriations bills. But I don't necessarily see that happening. I think they don't want to have a government shutdown in November when they control both houses. And the appropriations process has kind of been running somewhat normally. But I think the interesting thing right now about the appropriations process is a lot of the budget amounts, like if you look at the labor HHS education bill in the Senate, it has an increase of like $400 million or something. And then the cut in the labor HHS bill in the House isn't as big as President Trump had wanted. He had wanted like a 40% reduction to lots of different programs. So I think there's not as much of an incentive. I think the appropriations process will function normally. they'll kind of miss out on the second bite at the apple through reconciliation. Although I would anticipate they will probably not want to do another reconciliation bill before midterms, just because, it could create problems politically. But if they did keep the House, you might see another push for reconciliation in the future in 2028, probably with a focus on Social Security and Medicare.
Great. Thank you for that. Is anybody in the room? Yes, Alicia.
Hi, thank you very much for your talk. I think I got a good sense of what of the projected increase in uninsured patients in California. I was wondering how to put all of this together in terms of impact on health systems or even individual physicians who provide services to Medicaid patients, because I don't quite understand how that ends up coming down.
Right.
I'm going to add a related question that actually came in online around basically the same question of, if you have people who become uninsured, right? 2 million additional people in California who are uninsured, they're going to be showing up in emergency rooms and in physicians' offices and ending up in hospitals. So then how does that get paid for? Does that go on the back of the hospitals, on the clinicians, on the, so I think these are related questions.
Right. So, I think there's quite a bit of evidence about how financially stabilizing the Medicaid expansion was for hospitals and providers. And so if, I suppose the good news is the cuts are really targeted. The uninsured cuts will probably end up harming healthier people who use fewer services more, right? So if we're just cutting from by hoping to kick people off of Medicaid because they didn't turn in their eligibility form every 6 months and they couldn't do their work requirement, then ostensibly those people should be healthier and need healthcare less than their counterparts who are able to navigate their way to stay in. Like if I have diabetes, I'm probably
Yes.
going to prioritize making sure I hit my work requirement or volunteer requirement and stay in the program. So it might be that the group that's healthier will be more likely to go uninsured. Um, they will be able to come back, right? So there's a grace period. I believe there's like a 3 month waiting period built into the bill, but there could be people coming back when they actually need services, and you still have 1 to 2 months of retroactive enrollment to help pay back the provider that might have taken care of them while they're uninsured. So it's not a complete demolition of Medicaid, but it does mean we'll see a lot more turnover and churn and people going insured for longer periods of time and then probably coming back on the Medicaid program, triggering some payment and then leaving and not getting preventive care, maybe ending up in the ER more, that sort of thing. The biggest thing I think on the provider side will be if the provider tax is reduced by about 40% and the state directed payment is capped at 100% of Medicare instead of commercial rates, then the fees going to hospitals and providers will be lower. And so you'll have people having a harder time finding a provider that accepts Medicaid. But on top of that, the actual providers will be getting paid less even if they do take Medicaid. And there's no slush fund that the state has to fill that gap. And, what they used to do to raise more money to draw down additional federal match and pay better is now being reduced. And so they'll have a lot more buying power with their state dollar than they used to have.
Well, we are at the top of the hour. I hate to end on such a dour note, but there it is. Thank you so much, Dylan, for taking the time to present this. Super helpful. Keep it up with the CalSIM. Those data and those estimates for California are obviously extremely important to the state to understanding what the impacts of different policy options are. And we really appreciate your agreeing to be our first speaker of the academic year. It's wonderful to get to learn from you.
Great. Thanks for having me. Have a good day.